My name is Peter Cotton. With John Vargo, I'm chairing a session on Monday, May 21st at DDW entitled Quality in ERCP. We've selected two other speakers very pertinent to this topic who will be addressing their specific concerns and suggestions separately. My own presentation will review the evolution of ERCP from the early years, because I've had the privilege of performing this technique for over 40 years. In fact, I actually named it 40 years ago. In the beginning, it was most extraordinary revolution in medicine, gastroenterology, pancreatic biliary disease. At that time, there were no scans, and we diagnosed pancreatic and biliary disease with great difficulty, often with laparotomy, often indeed at autopsy. And the idea that you could get into the pancreas or bile duct with an endoscope was extraordinarily revolutionary. And we started off using it for diagnostic purposes, and then with the advent of sphincterotomy in 1974 and then stenting in 1979, we started doing the therapeutic things which we're all familiar with now. But other things have changed over the years. At the beginning, endoscopy or ERCP, sphincterotomy for stones, for instance, was clearly dramatically better and safer than the surgical alternative. Open surgery carried a mortality of 5 or 10%, even in the best of hands. But surgery has improved dramatically over the years, as have our other diagnostic tools, our CT scans, MRCP, endoscopic ultrasound, etc. So we're in a different situation now. ERCP treatments cannot be automatically assumed to be better, safer, cheaper than alternatives. And we find that there are a lot of questions around ERCP. For simple stones, things like that, leaks, low tumors, then clearly therapeutic ERCP is still a very good technique. But lots of questions have been raised, and randomized control trials are beginning to suggest that not necessarily the best treatment, for instance, for chronic pancreatitis. We're involved in a big study in sphincter dysfunction. The role of ERCP in pancreatitis in general is under question. And along with this has become an increasing interest in quality and safety, as in all branches of medicine. And it certainly applies at ERCP, where we know that it's the most dangerous thing that gastroenterologists do on a regular basis and can have very serious consequences. And that's why I've been particularly interested in quality and in measuring performance over the last decade or so, and why we're so keen to put forward this conference, this session of DDW, which will address those issues. The fact is that ERCP used to be sort of a little bit of fun for most gastroenterologists, but now it's evolved into a rather more sophisticated technique, which really should be done by relatively few people who have not only the training but the ongoing volume to be able to maintain their skills and hopefully improve them. I wrote an editorial about this recently, which was published in GI Endoscopy, called "Are Low Volume ERCPists a Problem in USA?" My answer to that, perhaps not surprisingly, is yes, and you will hear some data from Greg Cote particularly that emphasizes that. So our goal is to educate you about what is happening in the USA, what are the risks of ERCP, how we can perhaps minimize those risks by good training and by better organization. I hope you enjoy it.